Pathology. For today's talk, it's about approach to interstitial lung diseases. I would like to invite chairpersons for today's session, Dr. Rajiv Kaushal. Sir is a professor in Department of Pathology, Tata Memorial Hospital, Mumbai. And I would like to invite Dr. Pawan Kumar Beraris. Sir is assistant professor in Department of Pulmonary Medicine, Tata Memorial Hospital, Mumbai. Welcome you, sir. And to give the presentation today, I would like to invite Dr. Henry Tassiller, sir. Sir is professor in Department of Laboratory Medicine and Pathology from Mayo Clinic, Arizona. He will be talking about an approach to interstitial lung diseases today. And the moderators for today's session are myself, Narsimha Priyan, and I would like to invite my co-moderator, Dr. Meetu Mohanty. Ma'am is a consultant pathologist in ESI Dispensary, Bhubaneswar, Odisha. And I would like to invite webinar host for today, Dr. Anita Burgess, ma'am, and Dr. Sumit Gujral, sir. Anita, ma'am, is a consultant pathologist and Center of Oncopathology, Tata Trust, Mumbai. And Sumit, sir, is professor in Department of Pathology, Tata Memorial Hospital, Mumbai. These are certain reminders before starting the session. So kindly go through the reminders. And special request not to send any request for annotations to the presenter. And these are certain disclaimers for today's session. And a gentle reminder about upcoming talks, which is on 20th April. We have a slide seminar on FNAC of mediastinal lesions by Dr. Deepali Jain. Ma'am is a professor in pathology department in AIIMS, New Delhi. On 25th April, we have a session on cardiac dissection, explants and autopsies discussion with students by Dr. Uma Nahar. Ma'am is professor in Department of Histopathology, PGI Chandigarh. Now I would invite Dr. Henry to start the session. Over to you, sir.
Good evening, everyone. Thank you very much for joining us. We're going to talk about a pattern-based approach to the diagnosis of diffuse lung disease, or DLD. I have no disclosures. So let me... What do you do when you have a case of suspected diffuse lung disease? Well, we'll first look at the world of diffuse lung disease. Then I'll briefly discuss a pattern-based approach, a way for you to think about looking at a case of non-neoplastic lung disease. Then we'll talk about some mixed patterns and some of the subtle clues that you should look for in order to arrive at a more definitive diagnosis. And then briefly, a discussion on the importance of history and imaging in evaluating these cases. So what does the world of diffuse lung disease look like? Well, there are those with known etiologies or fairly specific histologies. These would be sarcoid, hypersensitivity pneumonitis, lymphangiomyomatosis. I won't go through all of these, amyloid. All of those things have either a known etiology or a fairly specific histology. Then there are those that fall into the unknown etiology category, and those have been called the idiopathic interstitial pneumonias. And I put interstitial in quotes because not all of these pneumonias, if you will, are actually interstitial. We don't have time today to go into a long discussion about that, but don't be surprised if we're not talking about the interstitium in some of these cases. So these are the classic interstitial pneumonias, and we'll go through some of these during the course of the talk today. So this is a beautiful Arizona black-tipped agave. Perhaps you have those in India as well, although I hear you're in the middle of a heat wave, maybe associated with rain, I don't know. So what are the definitions of patterns? Well, a form or model proposed for imitation, something that gives regular or intelligible form to, but I think the definition that works for us is consistent in recurring characteristics or traits that help in the identification of a lesion and serve as an indication or model for predicting future behavior. That's really what we would like to do when we're giving our clinicians a diagnosis. So here are the 6 basic patterns of diffuse lung disease: acute injury, fibrosis, cellular infiltrates, alveolar filling patterns, nodules, and minimal change. So acute injury is best characterized by diffuse alveolar damage, where we see these very florid hyaline membranes. Fibrosis can look like this. So this is diffuse interstitial thickening admixed with inflammatory cells in a case of cellular and fibrotic nonspecific interstitial pneumonia. Cellular infiltrates expand the interstitium with inflammation, usually chronic inflammatory cells. This is an example of a cellular nonspecific interstitial pneumonia. Alveolar filling can be by cells or by blood. In this example, this is filling of air spaces by proteinaceous material in an example of alveolar proteinosis. Nodules can look like this. So this is an example of sarcoidosis, and I know that Dr. Mukhopadhyay spoke with you last week on granulomatous inflammation, but these are the well-formed granulomas following a nice lymphangitic route. Here's the pleura, which is also involved in a case of sarcoidosis. And then there's minimal change. What do you do when you get a biopsy that looks virtually normal? Well, take a look at the vessels and the small airways. This is an example of obliterative or so-called constrictive bronchiolitis, but the lung parenchyma here is relatively normal. So those are the 6 main patterns. Now we'll focus in on the acute lung injury patterns. We've already talked about hyaline membranes, but one can also see airspace fibrin or organization or organizing pneumonia as a manifestation of acute lung injury. So here's another example of diffuse alveolar damage, lots of hyaline membranes. Notice that the interstitium here is also thickened and edematous and has interstitial fibroblastic proliferation. If this process is idiopathic after you or your clinicians have excluded an underlying etiology, then you can call it acute interstitial pneumonia. But on the bottom line, you're likely to just put diffuse alveolar damage. Now, here's how acute interstitial pneumonia gets its name. In the later stages of diffuse alveolar damage, you get this very prominent interstitial fibroblast proliferation, leading to this low power appearance. If you look carefully, you can occasionally see residual hyaline membranes. But again, you can't call it AIP unless you know it's idiopathic. Here's airspace fibrin and organizing fibrin, a so-called pattern that has been called AFOP, or acute fibrinous and organizing pneumonia. If this pattern is idiopathic and not associated with infection, for example, you can call it acute fibrinous and organizing pneumonia. The classic airspace organization and bronchiolar organization we see in what used to be called BOOP, or bronchiolitis obliterans, for the airway component with organizing pneumonia. But you can see this organization in either location, and currently that's accepted as organizing pneumonia. Here's another example. Bronchiolar organization and airspace organization. We put that together and we can call that organizing pneumonia. So if it's idiopathic, we can call it cryptogenic organizing pneumonia. These can have unusual forms. So this little bunny over here is an area of organizing pneumonia. This bunny has lost its ears somewhere along the line. But these are examples in what organizing pneumonia can look like. This is a diagnosis you can make on a transbronch, a cryobiopsy, or as shown here, a large VATS biopsy. Moving on to fibrotic patterns, there are those that are heterogeneous, meaning they don't look the same from field to field, or homogeneous. And we'll take a look at two patterns, a diffuse homogeneous pattern, as well as airway-centered homogeneous patterns of fibrosis. The classic heterogeneous pattern of fibrosis is usual interstitial pneumonia, the pattern that we associate with idiopathic pulmonary fibrosis. Here at low power, we see areas of normal lung in areas of fibrosis that are typically subpleural in accentuation. Here are areas, and we can see the fibroblast foci here that are characteristic of UIP, showing up as these pale bluish areas of organization. And then some cases, but not all, will have areas of honeycomb change. Here's a homogeneous diffuse pattern. So there's definitely a low power pink appearance to this lung biopsy because of all the fibrosis. This also a little bit different appearing, but a diffuse pattern of fibrosis where all of the alveolar walls are thickened. This is a fibrotic NSIP pattern. No fibroblast foci, no honeycomb change. Here's an example of airway-centered fibrosis that's very homogeneous. It looks like it's all the same age, and it's all peribronchiolar. This happens to be a case of severe end-stage hypersensitivity pneumonitis. This patient had over 300 birds in their apartment. Not good, but there were no granulomas or giant cells in this example. Another etiology for this pattern can be aspiration. So this is your first question. So time to put your thinking caps on. I know you've had a long day of looking at cases, but hopefully you have a little energy left. This is a 21-year-old man with daily marijuana use, and he presented with persistent shortness of breath and cough. A CT scan showed innumerable bilateral 1 to 2 millimeter peribronchiolar nodules. The biopsy shows which disease, and here are going to be your choices. And here's the slides. Airway-centered, somewhat stellate nodule. And here's the higher power. Pigmented macrophages are included. And then we have this inflammatory appearing infiltrate. So there's your question. So you can respond in the chat.
Everybody seems to answer C.
C is the answer,
C.
sir. C is
Okay. All right. Well, this is the CD1A stain. Does anyone want to change their diagnosis? This is Langerhans cell histiocytosis. So stellate central lobular scars with those small histiocytes, the Langerhans cells. So Langerhans cell histiocytosis is only one of the manifestations that you can get from marijuana smoking. So it's very similar to what we see with ordinary cigarettes. But just be aware that marijuana can do very similar things. All right, we'll just return to another example so you can get, cement these small Langerhans cells in your mind. They have folded and grooved nuclei. They sometimes have a groove up the middle, so I like to call them buttock cells. They're occasionally admixed with the eosinophils. So some cases, like I showed you, can be cellular and fibrotic, but some can be a bit more cellular, as we see here. But they are still airway centered. Healed LCH can look like this. where you get these central lobular scarred zones and no residual Langerhans cells. All right, now we're going to move to an airspace filling patterns. We'll look at prominent pigmented macrophages and then eosinophils, both of which can fill air spaces. Respiratory bronchiolitis refers to the accumulation of lightly pigmented macrophages in and around terminal bronchioles. It's a common incidental finding in the lungs of cigarette smokers and rarely those with other exposures. The presence of respiratory bronchiolitis as the only finding in patients with signs and symptoms of ILD allow you to call that patient as having respiratory bronchiolitis, interstitial lung disease. That really cannot be made without knowing the history and without a conversation with your pulmonologist or the patient's pulmonologist. Here's what it looks like under the microscope. Here's these lightly pigmented macrophages. This is a result of cigarette smoke or marijuana smoke. Now, here's an image with lots of small central lobular nodules. So is this respiratory bronchiolitis or respiratory bronchiolitis interstitial lung disease? Well, it could be either. You don't know until you talk to the patient's pulmonologist and determine whether the patient is even symptomatic or not, because respiratory bronchiolitis, as I mentioned, can be a very common incidental finding in cigarette smokers. A closely related lesion is desquamative interstitial pneumonia, or DIP. These same alveolar macrophages fill alveolar spaces in a very homogeneous pattern. There are not a lot of fibroblast foci, giving it a look of UIP, for example, and it's generally very homogeneous in the areas that are involved. There's general preservation of the lung architecture, and as we'll see, some cases are going to be along the spectrum of being peribronchiolar, like we see with RB, and more diffuse. So here's an example of DIP. There is an interstitial pneumonia here. There are prominent airspace foamy or pigmented macrophages, however, as we see here. So RB and DIP are along a spectrum of smoking-related disease. You can see incidental RB in patients who have undergone lobectomies for lung carcinoma. RB can also give patients asymptomatic radiographic abnormalities, but then RB can also be an explanation for breathlessness and restriction. Those patients have RB-ILD. When those changes are more diffuse and severe, we call it DIP. And in individual cases, somewhere along this spectrum, you may not be able to know which bucket to put it in, but the point at that for the clinician is this patient needs to quit smoking. All right, question 2. This is a 56-year-old man, a smoker with shortness of breath, fever, and weight loss. Chest CT and X-rays show peripheral infiltrates, and he has peripheral eosinophilia. So here's a low power appearance and a higher power appearance. And then yet one more high power appearance. Note that the alveoli are just flooded with cells. So the best diagnosis based on the history and images is which of these?
See, the most common answer is A.
A, okay, acute eosinophilic pneumonia. This is actually chronic eosinophilic pneumonia. Eosinophilic lung diseases are a spectrum. Chronic eosinophilic pneumonia is airspace filling with eosinophils and macrophages, like we saw in this case. Acute eosinophilic pneumonia presents with a much more acute presentation, typically less than a month. This patient, as we know, actually lost weight and was quite sick and had peripheral eosinophilia. Acute looks like DAD with a lot of EOs. So this histology really was more airspace filling with eosinophils and macrophages. On the spectrum of eosinophilic lung disease is allergic bronchopulmonary aspergillosis. That can have a variety of histologies. You can see allergic mucin in the airways, eosinophilic pneumonia in the parenchyma, and then airway-centered granulomas as a manifestation of bronchocentric granulomatosis. So now let's take a look at some mixed patterns. Here's the natural history of UIP-IPF. At some point, the patients become symptomatic and they may undergo a biopsy which shows UIP. Most patients sort of grumble along with slowly progressive shortness of breath, but a proportion of patients have what's called an acute exacerbation of IPF. On a biopsy, those patients can have either organizing pneumonia on top of UIP or DAD. Now, it really depends on how good a biopsy you have as to what you're going to see if the patient is in an acute exacerbation. You might only see UIP because the biopsy missed the acute lung injury. You might only see acute lung injury because the biopsy is not large enough. However, hopefully you will see both patterns. So here's a low power appearance of a patient with idiopathic pulmonary fibrosis. Here's this peripheral fibrosis. But if you look over here, there's a more dense area of airspace filling, if you will. And this is a focus of diffuse alveolar damage. There are hyaline membranes, as well as areas of organization. This is an example of an acute exacerbation of idiopathic pulmonary fibrosis. Another very challenging area is mixed patterns of UIP and NSIP. So we talk about NSIP as being homogeneous, but it can have some degree of heterogeneity because you can see areas of organizing pneumonia in NSIP, rarely fibroblast foci and honeycomb change. Also, to make things even more confusing, UIP can have NSIP-like areas. And then you can see NSIP with granulomas, a mixed pattern. So here's a field of organizing pneumonia, but if we take a step back in this case, the rest of the case looks like this. So this is a case of NSIP, cellular NSIP with organizing pneumonia, and OP, small areas of OP can be present in about 50% of patients with NSIP. So don't let the OP areas in a case that you think is NSIP preclude you from seeing the NSIP in the background. Here's a small fibroblast focus, this area of recent organization plastered up against a smaller area of fibrosis and a thickened interstitium. But if we step back and look at where that is, there's the one fibroblast focus in what is overall a very homogeneous case of NSIP. Here's a case of NSIP, no fibroblast foci, but has areas of honeycomb change like this in another field. That can be seen in about 5% of patients with fibrotic NSIP. So again, all of the features need to be present for you to call it UIP. Just because there's honeycomb change doesn't mean it's a case of UIP. In a study done by Dr. Katzenstein a number of years ago, she looked at both explants and biopsies, and in explants, NSIP-like areas were seen in about 85% of patients with UIP, and 80% of patients who had biopsies, which overall showed UIP, had areas that looked like NSIP. So here's a case of UIP. nice fibrosis, peripheral fibrosis leading to central, with central sparing fibroblast foci. But in another lobe, we saw areas that look like NSIP, a much more uniform pattern of interstitial thickening and fibrosis. That was also exemplified by a study that looked at two lobes, upper and lower, say, independently. And they were diagnosed independently as though they didn't belong to the same patient. And if patients had NSIP in both lobes, those patients had a survival that was that of NSIP. If, however, they had UIP in one lobe and NSIP in another, or UIP in both lobes, those patients had a survival of UIP-IPF. Those were called discordant UIP cases. But the point is, anybody who has UIP in one lobe has UIP, and you don't really need to worry about the areas that look like NSIP in those cases. Although, you know, if you wanted to comment on that, that would be fine, but those patients are going to act like they had UIP, IPF. All right, so here's another question for you. A 42-year-old woman has cough and shortness of breath. A CT shows bilateral upper lobe, central lobular, ground glass opacities, and evidence of air trapping. Air trapping is a sign that the patient typically has some degree of airway disease. And the gas is not able to be expired because there's usually a constriction of those small bronchioles. So here's her biopsy, and those are the answers you have, the same set that I've been giving you earlier. So a cellular interstitial pneumonia, airway centered, loose, non-necrotizing granulomas in giant cells, as we see here, as well as areas of organizing pneumonia. Now, hopefully after last week, you will know what this is. Special stains for organisms and cultures were negative. She's not on any drugs, and a workup for connective tissue disease is negative. So, what do we think of this biopsy?
So the most common answer is being C, followed by E.
All right, great. This is hypersensitivity pneumonitis. In respiratory bronchiolitis, you don't typically get granulomas. So I think we have granulomas. The air trapping is also a clue, and I understand that you're not radiologists, but you do need to understand a little bit of chest radiology in order to really do lung pathology, non-neoplastic lung pathology. So these are the major patterns that one can see in hypersensitivity pneumonitis. Like in this case, a cellular NSIP background, but you can also see a fibrotic NSIP or a UIP background. What we really want to see is bronchiolar inflammation with granulomas. And as I showed you, we had an example of bronchiolocentric fibrosis earlier. Remember that not all patients with hypersensitivity pneumonitis will have granulomas. And the more fibrosis you get, the fewer the granulomas and giant cells. So now let's look for some other subtle clues to maybe what the underlying etiology of these cases is. Here's a low power appearance that looks very much like UIP, peripheral fibrosis. It's heterogeneous because there's areas of more central sparing, but there's sort of a lot going on in here. So let's look at that at higher power. Here's a nice fibroblast focus. But there are also areas of peribronchiolar metaplasia, the proliferation of benign ciliated pseudostratified columnar epithelium along alveolar walls as opposed to just being along bronchioles. And then if we look even closer, we see scattered multinucleated giant cells. So when you see giant cells, you need to look a little closer for granulomas or things that look like this. So these are giant cells associated with blank spaces, empty looking spaces, as well as this. That is last week's lunch. This patient is aspirating. Over here on the left, this is aspiration of lipid. And what I just showed you here is vegetable material that's partially digested. It would not polarize. So you need to be aware of that as well. I think in this case, I know for sure that this patient is aspirating. What I don't know is whether all of the changes that we see here are due to aspiration or whether the patient might have a background interstitial pneumonia. And I think that's, again, when you need to have a conversation with the pulmonologist. But both of these images, this would be exogenous lipoid pneumonia, but in this patient, we also had aspirated food. So this patient has a number of different things that are ending up in their lungs. Here's another case, a low power that appears very homogeneous. We don't see subpleural fibrosis like we associate with UIP. It's very uniform, looking very NSIP-like, if you will. On higher power, however, this interstitium looks a bit edematous. In this field, no acute lung injury, but there is edema in the interstitium in a way that ought to make you think twice about this being a straightforward case of NSIP. Then in other fields, we see this interstitial organization and some remnant hyaline membranes, fairly subtle. So this is a case of late diffuse alveolar damage, which is mimicking nonspecific interstitial pneumonia. If you go back to the history, which is so important, this patient was presented with only 3 days of shortness of breath and then was in the emergency department. So that's a very unlikely history for someone with nonspecific interstitial pneumonia. So you need to correlate what you're seeing under the microscope with the clinical history. The patient was slowly improving on steroids, but wasn't getting better very quickly. And that's pretty typical for someone with diffuse alveolar damage. What would I put on the bottom line? Cellular interstitial pneumonia with organization and focal fibrin, again, correlating with the history, most consistent with the late stages of organizing diffuse alveolar damage. So you cannot do this job without paying attention to the history. So, as you prepare for tests and boards, for example, the history will often give you a hint as to what's going on the slides, particularly in these cases of non-neoplastic lung disease. So just to summarize how you approach suspected cases of interstitial lung disease, the disease must be diffuse. Again, you need to know what the imaging looks like. You can see focal honeycomb change due to a lot of different things. The disease has to be diffuse if you're thinking about making a diagnosis of UIP. Remember what UIP looks like. That's really what the clinicians want to exclude the most or be firm about a diagnosis, if at all possible, that has the worst prognosis. And patients with UIP can receive medication, but it's very expensive and has a lot of toxicity. So you really want to understand what UIP looks like. The pattern-based approach is helpful. Read the history and then work closely with your clinicians and radiologists because working together, you can usually arrive at a reasonable diagnosis for the patient. So this is a classic Arizona image. This is us hiking down into the Grand Canyon. So if you ever get here, a great place to visit, one of the spectacular natural wonders in the world. And now I'll turn this over to Drs. Rajiv and Kumar to see if they have any additional comments.
Excellent talk, Dr. Tesler, and you have summarized the whole story of ILDs in last 40 minutes. And the journey and the diagnostic approach which you told how to approach these cases is really amazing. And I think we'll feel it more comfortable to report when we'll come across these cases in our routine practice. Pawan, any comments from your side?
Yes, sir. Thank you, Dr. Tasler, for this wonderful talk. It's always a great learning experience listening to you. As a clinician's perspective, I can say that if I have a HRCT finding of a typical UIP, we don't do biopsy. So whenever it comes to you, it's always a dilemma in our mind. There is a clinical radiological discordance, and we want a proof, and proof lies in the tissue. So you are the ultimate deciding factor in patient's management. I highly every time I contact my pathologist, I give them the detailed history. So whenever there is clinical radiological discordance, always contact your clinicians if he's not provided your history. As for the as professor also has emphasized on that, he asked for radiological patterns. What is your clinical differential? What is your differential? And then take calls accordingly on defining the patterns on histopathology. Also look at the CTD, serology markers. If you have a connective tissue disorder marker positive, sometimes like NSIP is more common than the UIP patterns in the CTD-ILD. That's how we dissect the clinical situation. And remember that whether the patient is on particular drug, patient any serological markers positive, any COVID-19 recent infection, a lot of fibrosis also we got after the COVID-19. So look at all these things. And if somebody is immunocompromised, and we get these patients, a lot of patients in Tata, when there is a lot of ground glass opacity, some area of fibrosis, there is a confusion whether it's HP, because there's a lot of pigeon exposure in Mumbai. And, these patients in biopsy turned out to PCP. The clinical markers were negative, but Dr. Rajiv has given us diagnosis, no, it's PCP. And that's a simple medication like cotrimoxazole, which is very cheap and it cures. It actually cures the problem. So I think we need more and more pathologists trained in lung pathology, doing even a virtual MDT or phone MDT will make life easier. So we always rely on Dr. Rajiv and our other pathology colleagues. We are keen to give you more and more tissue, but give us an answer. So this kind of programs will definitely encourage them to pursue the pathology career in lung pathology. Thank you.
Thank you. Yeah, it's becoming a real challenge to help the pulmonologists because as he mentioned, they're not diagnosing cases that look like straightforward UIP, IPF. Therefore, the cases that you tend to get, in your lab are the challenging cases. They're not going to be straightforward. There's going to be one or two giant cells. Well, what does that mean? Is that enough to call it chronic HP? I think in the pathology world, we still don't know the answers to those questions. What does one granuloma mean? In a case that otherwise looks like a fibrotic UIP, is that hypersensitivity? Does the patient have a superimposed infection? Did we miss the focus of aspiration? So I think imaging can be helpful, and the history, but it doesn't always help. And occasionally you're still stuck even after a biopsy. And, cryos are good, but they're not perfect either. And, we try to glean as much as we can out of them for the clinician. I think part of our job is to say how much fibrosis there is, because if there's a lot of fibrosis, the patients aren't going to respond to really anything. If it's cellular, then the likelihood is that there might be some response to either steroids or other immunosuppressive agents.
Absolutely agree with
Yeah, I completely agree. The more tissue you give to a pathologist, he will be more comfortable. But we do feel this problem with the tissue, especially in India, because very few centers do the open lung biopsy or VATS biopsy. So, Dr. Tesla, in which cases we as a pathologist can be can be comfortable to offer a definitive diagnosis of ILDs, especially in the small tissue biopsies?
I'm sorry, I missed the first part of your question, Rajiv.
So, in a limited tissue biopsies, because that is a very common practice in India. So, in which indications you are more comfortable, or if there is you are not certain on the limited biopsy, how do you approach that case?
I mean, I think the diagnoses that are easiest on a small biopsy are those with acute injury, because you can see organizing pneumonia, you can see hyaline membranes, you can see fibrin that ought to allow you to say this is DAD or this is organizing pneumonia. Now, organizing pneumonia can have multiple etiologies. We didn't really talk about that, but I would always do bug stains on those acute lung injury cases. It's a little harder in the and if you see a lot of EOs, right? I mean, then you can get to either one or the other variant of eosinophilic pneumonia typically. You can make a diagnosis of Langerhans cell histiocytosis, but you have to think about it and you have to order a CD1A stain to confirm it if you don't, if all the features aren't classic. It's harder in the fibrotic cases, but if you get honeycomb, sparing, and fibroblast foci, you can lean towards UIP. If it's uniform, you can uniform fibrosis, even though you have a piece that's normal, you could call it NSIP. So I think you can get further down the road, but the acute injury cases are easier on a small piece than the fibrotic chronic cases. There's just no question about it. And always do levels. In our consult practice, we see a lot of cryobiopsies, and the outside pathologist will only have done one level. You've got a lot of tissue in that block, and by increasing the number of levels you do, you may find giant cells, you may find acute injury you didn't see on the first level, or other features. I've seen food on cryobiopsies with organizing pneumonia, and the food is only on one level. So, I mean, that's something easy and cheap that we can all do to increase the likelihood on a small piece of tissue that you're going to get to a more specific diagnosis.
Sir, Dr. Yadav, you have already mentioned about how to differentiate between the fibroblastic foci and OP. Can you, because that can be sometimes really challenging to decide, is it
Right.
organizing pneumonia or fibroblast? Can you little bit re-emphasize
Sure.
on that?
Sure, thank you. Yeah, so fibroblast foci are little plaques of proliferating fibroblasts, that bluish organizing pneumonia look, all right? They look the same, but they're plaque-like and they're up against areas of older fibrosis. And they're not very big. They're usually fairly small. Organizing pneumonia is going to look, so the classic OP is cut like this, where you see this nice round plug of organizing tissue in an alveolar space or a bronchiole, as I showed you. But you should see adjacent, relatively normal alveolar walls. They're not, they look like they're floating in the airspace rather than being up against older areas of fibrosis. And then they can branch, like I showed you. So depending on the way it's cut, it may have multiple little tongues, like that ears of the bunny that sort of look like they were chopped off, right? Fibroblast foci don't do that. So look for those more unusual patterns in a background that is not so fibrotic. Are there cases where it's difficult on a small biopsy? Absolutely. And the smaller the piece of tissue, the harder it might be to sort out whether it's a fibroblast focus or organizing pneumonia. But that sometimes getting deeper levels will help, because you'll see more of what more of those plugs that may allow you to say, well, this is more like organizing pneumonia. But it's the same bluish appearance. It's really, how big are they, and are they associated with old fibrosis, like you should see with fibroblast foci?
Yeah, thanks. But sometime they become really tricky because in a
Absolutely, I agree with you. Yeah, yeah.
I have two questions, if I can ask.
Yeah, Dr. Pawan, please go ahead.
Yes. So when there is an evolving hypersensitive pneumonitis, when it goes into a subacute chronic phase, now these terms are not there, but when it goes from a inflammatory to a fibrotic phase, and these patients come to us with exacerbation, they are not even stable to do any bronchial lavage or biopsy. But whether we should take the BAL count, the lavage count, the cell count of more than 30% lymphocyte in presence of a fibrosis, should we take it as HP or should we consider it as some other diagnosis?
Well, the BAL count, I think in the guidelines is sort of a low evidence, right? So, CTD always enters the differential for those cases as well. And so I don't know, you would probably know better than I do about how specific that BAL count is in distinction from a drug reaction. Of course, you would know whether the patient's on a drug, but whether they could have an evolving connective tissue disease. I don't know the answer to the CTD differential quite so much. And classically that differential is versus sarcoid, right? Sarcoid, you get the reverse of that, and in an ILD, in HP, you get a high CD4 to CD8 count, I think, right? So I think it's helpful information. It probably means it's not IPF.
Yes.
Because then you're going to get neutrophils. But I don't know that it always means it's HP.
Thank you. Thank you.
Do you have any questions here? I don't see many questions, Henry, here. The people are very happy listening to you, so maybe they have understood everything. So
well, I doubt that, but I hope so.
Yes, I'm sure. I'm a hematopathologist. I enjoyed it thoroughly. Rajiv, you or Pawan, do you have any comments before I request Henry for his final comments then?
Yeah, I have one or two doubts for me. So, Dr. Razwa, in ILDs, how frequently you see the coexistence of other infections like tuberculosis or malignancies? Because we are an oncology-driven center, and whenever there's a patient comes to us with a lung mass, the all attention goes to the tumor, and the ILD or the background disease is neglected. So maybe we are underdiagnosing our case, our ILD is in. So both Pawan and I need your comments on that.
I would say that we definitely see cases where there's a tumor and there's a background of UIP, IPF, or another fibrotic disease. You're correct that they're often missed initially, and then later someone will come back and say, oh, actually on imaging, this patient has a background ILD, so can you put up more sections to look at the ILD? So that's a common scenario, and there is an increased risk of carcinoma developing in patients with pulmonary fibrosis. So there is that association. So plus they're often smokers, right? So patients with IPF are smokers. Lung cancer occurs more often in smokers. So I think you should, if you sample your lung tumor and in the background you begin to see fibrosis, you ought to put up some more sections and try to determine what the background fibrosis is. I think in our practice, most cases of ILD are pure. So, you know, you don't, I mean, I showed you a case of UIP with probable aspiration as well, but those are pretty uncommon. So, I mean, I know that in India, you get, you know, you certainly have more TB and other infections than we do. So that could be in the background, but your clinicians are pretty good at knowing kind of when it looks like TB versus something else. But I wouldn't be afraid to make two diagnoses. We did a study a number of years ago looking at granulomatous lung disease, and in those cases, 5% out of 100 had more than one granulomatous lung disease. So, you know, two diseases do occur, and I think we always need to be on the lookout. If you see acute lung injury in what looks like a fibrotic case, you need to do bug stains, and you need to consider what else might be going on. Is it just an acute exacerbation of that fibrosis, or could it be something else? You know, and I think infection, you know, PJP, you know, is always, because you don't, those patients may be on steroids, right? Because even though they shouldn't be on steroids for IPF, maybe somebody put them on steroids and now they have an infection due to that as well. So they do occur, and we always have to be on the lookout for not missing, you know, those sorts of problems.
And Pawan, any experience from your side?
Yeah, like TMH experience itself shows that, you know, this UIP or even NSIP, which is common in lower lobes, most of times, if this coexistent malignancy starts in the area of fibrosis, and usually when like COVID also has shown that when there is frequent scans have been done, we picked up malignancies in them on background of fibrosis. So it's not very uncommon. Like, it's not uncommon that we will not get a malignancy together. In terms of tuberculosis, yes, and I think a BL will be a very much additional test which should be done when there is a clinical suspicion, because then you will be asking for a cartridge-based nucleic acid amplification test for tuberculosis and cultures together, so that your tuberculosis query is sorted out. But most of the times they will have a lesion on the CT scan, which will guide us, you know, I need to do a BL also for microbiological purpose. And the doubt mostly comes in terms of lymph nodes, because these patients frequently get respiratory infections. They get lymph nodes also are more common in this patient. And whenever there is a lymph node, there is a TB question always in Indian scenario. So we tend to do an additional EBUS test when we tend to do a lung biopsy, especially a cryo with them. So yes, Indian endemic settings, these are common findings.
Yeah, one of the you and I were talking earlier about our, you know, time in Bangalore, and I know that you were doing EBUSs as part of your workup for ILDs, and the hypersensitivity patients, even though you typically don't biopsy the lymph nodes, also had non-necrotizing granulomas, possibly related to the hypersensitivity reaction. So as opposed to TB, but I remember having those conversations with you.
Yes, very much agree, Professor. Because of the recurrent infection, any inflammatory respiratory process will have some lymph node in them. So yes, getting sarcoid like granuloma or granuloma of the HP are very common. And later on, we changed the practice that we stopped doing the lymph node biopsy and concentrated more on lungs.
Wow. Okay.
One last question, if I can take. My questions are maybe related to our problems. So many times we do a lot of oncology, and sometimes the pulmonologists, they question, can you tell us if the patient has his PFTs are deteriorating, and can you tell whether it is related to the drug toxicity or the pulmonary drug toxicity? So how is your experience or about the drug toxicities, especially the chemotherapeutic agents?
Well, you know, there are very few specific features of drug reactions. So it really, again, is a clinical pathologic correlation. You've got to have the drug that, you know, can cause that kind of injury. Of course, there's always a first time, but I always go to pneumatox.com, you know, which lists all of the drug toxicities that can occur. I always want to exclude infection, particularly when there's acute lung injury. So, they're on a chemotherapeutic agent. But, if the history is compelling and you have histology that's consistent, then I think, along with the clinician, a phone call, you can say, I think this fits for a drug reaction. It's hard to prove a drug reaction because there's almost no specific histology. But I think if you put everything together, you can usually suggest that we still see a lot of amiodarone toxicity. So you mentioned chemotherapeutic agents. Certainly you do there, but amiodarone can also, is probably still one of our more common drug reactions to see in our consult practice.
And are you seeing any cases where, because immunotherapy is also now given to a lot of patients? So
yeah, you can see granulomas in immunotherapy, as well as acute lung injury, organizing pneumonia, DAD, but also granulomatous inflammation. So yeah, that's probably another one that we see these days a little more commonly. Yeah, good. Thanks for asking that.
yeah, because they are not, we don't see them more commonly, but our pulmonologist, especially Dr. Turner, he keep on asking, so if I give you tissue, will you give me a definite diagnosis that this is drug induced or not?
Yeah, well, it can never be, it's hardly ever definite.
So now I can quote you.
Yeah, I mean, but I think you have to put the clinical, and I think you can go a long ways to saying, I suspect this is a drug reaction, by knowing the history and the pathology.
Thank you so much, and over to the moderators and Dr. Gujral.
Thank you, Henry, very much for a wonderful presentation. And I thank both the chairpersons, Rajiv and Pawan, for being there. Over to you, Narshima.
Thanks a lot for the wonderful session, sir. And I would like to thank the chairpersons and the host, Gujral sir. I would like to gentle reminder about the upcoming program here. So we have a slide session.